Chambersburg, Pennsylvania, September 17, 1862. The Battle of Antietam has just ended. 23,000 men lie dead or wounded across a 12-mile stretch of Maryland countryside. It remains the bloodiest single day in American military history. Among the wounded is Corporal Jacob Miller, 2nd Wisconsin Infantry. A Confederate sharpshooter's Minié ball, a .58 caliber conical projectile weighing 505 grains, has struck him just above the left knee. The bullet entered at an angle, shattered his femur into at least 7 fragments, severed the femoral artery, and exited through the back of his thigh, taking muscle tissue and bone splinters with it. Miller is fully conscious when stretcher bearers carry him 3 miles to a field hospital established in a tobacco barn owned by a farmer named Samuel Poffenberger. He remains conscious when they place him on a blood-soaked door that's serving as an operating table. And he is still conscious, agonizingly, unbearably conscious, when Surgeon Charles McDougall of the 2nd Division Medical Corps picks up a capital saw and begins cutting through what remains of his shattered femur. There is no chloroform, no ether, no laudanum, not even whiskey. The Union supply wagon carrying medical anesthetics had been captured by J.E.B. Stuart's cavalry raiders 4 days earlier during a raid near Poolesville. The Confederate forces used what they could and destroyed the rest to prevent recapture. Dr. McDougall had exactly 3 bottles of chloroform remaining for an estimated 400 men requiring immediate surgery. Jacob Miller was not one of the men who received it. 4 orderlies held him down, 2 on his arms, 2 on his remaining leg. A leather strap was placed between his teeth, and then the surgery began. Miller later testified before the U.S. Pension Bureau in 1867 that he could feel the initial incision through skin and muscle. He felt the scraping sound and sensation as the saw teeth bit into exposed bone, and he felt every one of the 43 seconds it took Dr. McDougall to sever the femur completely. He stated, and I'm quoting directly from the pension record, "I believed I was in hell. I believed God had abandoned me to punishment for sins I did not know I had committed. The pain was not located in my leg. It was located in my soul." This is not folklore. This is documented medical history, and what I'm about to tell you has been systematically excluded from every American history curriculum, every Civil War documentary series, and every battlefield memorial you've ever visited. Because the truth about Civil War medicine isn't just disturbing, it reveals a failure so profound that it's easier to pretend it never happened. Between April 12, 1861, and May 9, 1865, approximately 60,000 amputations were performed on Union and Confederate soldiers. Modern research from the National Museum of Civil War Medicine, cross-referencing Surgeon General reports with pension records and hospital ledgers, suggests that somewhere between 21,000 and 27,000 of those amputations, roughly 40%, were conducted with inadequate anesthesia or none at all. Let me repeat that number: 27,000 men. That's not counting the tens of thousands more who underwent other surgeries, bullet extractions, bone resections, abdominal procedures, also without anesthesia. And of those 60,000 amputations, approximately 26,000 men died afterward, not from the original battlefield wound, from infection, shock, hemorrhage, or complications stemming directly from what the surgeons did in attempting to save them. The survival rate for a major amputation during the Civil War was roughly 73% if performed within 48 hours of injury. But that number drops to 46% when you factor in deaths from post-surgical infection within 30 days. For amputations performed without anesthesia, the shock-related mortality rate climbed even higher. Tonight, we are examining the medical catastrophe that destroyed a generation of American men, not the mythology, not the sanitized version taught in schools. The truth that was buried along with 26,000 amputees who should never have died. To understand what happened inside those surgical tents, you must first understand the state of American medical science in 1861. The United States was not a leader in medical innovation. That distinction belonged to France, Germany, and Great Britain. American physicians were, by and large, trained through apprenticeships rather than rigorous university programs. Many had never attended medical school. Some had never dissected a human cadaver. When the war began, the Union Army Medical Department consisted of fewer than 100 surgeons, for an army that would eventually swell to over 2 million men. The Confederacy had even fewer, approximately 24 trained surgeons at the outbreak of hostilities. Both sides scrambled to recruit civilian doctors, many of whom had never treated a gunshot wound, never performed an amputation, and never worked under battlefield conditions. They learned by doing, and men died while they learned. Now let's address the science, or lack thereof, that governed their work. Germ theory, the understanding that microorganisms cause infection, had been proposed by French chemist Louis Pasteur in the 1850s, but his work was not widely accepted in the American medical community until the 1880s. That's 15 to 20 years too late for the 620,000 men who died during the conflict. Dr. Joseph Lister's revolutionary work on antiseptic surgery, using carbolic acid to sterilize instruments and wounds, was published in The Lancet in March of 1867, 2 years after Appomattox. What this meant in practical terms was catastrophic. Civil War surgeons operated in their street clothes. They wore aprons, often leather or canvas, that were stiffened with the dried blood of previous patients. The more blood on your apron, the more experienced you were considered to be. It was a badge of honor. Surgical instruments were rinsed in cold water between operations, if they were cleaned at all. Many surgeons simply wiped their scalpels on their pants and moved to the next patient. Sponges used to clean wounds were wrung out in a bucket of water and reused dozens of times. Dr. W. W. Keene, who served as a Union contract surgeon and later became one of the founding members of the American Surgical Association, wrote in his 1905 memoir, "We operated in oldie, blood-stained coats. We used undisinfected instruments from undisinfected plaster-lined cases. We used marine sponges which had been used in prior puce cases and only washed in tap water." He added, "If a sponge or instrument fell on the floor, it was washed and squeezed in a basin of tap water and used as if it were clean." They weren't being negligent by the standards of their time. They genuinely believed they were practicing good medicine, but every one of those practices introduced bacteria directly into open wounds. And without antibiotics, penicillin wouldn't be discovered until 1928. Those bacteria killed thousands of men who should have survived. Now, regarding anesthesia, ether had been successfully demonstrated as a surgical anesthetic at Massachusetts General Hospital on October 16, 1846, in what became known as the ether dome demonstration. Chloroform followed shortly after and was considered superior because it acted faster and required smaller quantities. By 1861, both were known to the medical profession. Both were used in civilian hospitals. Both were theoretically available, but theory and reality on a battlefield are two very different things. The Union Medical Department was chronically, catastrophically undersupplied. Quartermasters prioritized ammunition, food, and uniforms. Medical supplies came last. Requests for anesthetics were often denied or reduced. Shipments were delayed. Bottles broke in transit. The Confederate situation was exponentially worse. The Union naval blockade of southern ports restricted imports of pharmaceutical-grade chemicals. Chloroform that cost $2.50 per bottle in New York sold for $40 in Richmond by 1863, when you could find it at all. Southern chemists attempted to produce chloroform domestically, but the quality was inconsistent and sometimes dangerous. There are documented cases of Confederate patients dying from impure anesthetics that contained toxic impurities. By late 1864, many Confederate field hospitals had no anesthesia whatsoever, but even Union surgeons with access to supplies faced impossible choices. Dr. John H. Brinton served as a surgeon at the Battle of Shiloh, April 6th through 7th, 1862. In his official report to the Surgeon General, he recorded performing 47 amputations in a 20-hour period. He had 4 bottles of chloroform. Each bottle contained approximately 4 ounces. Each dose required roughly half an ounce to 1 ounce to achieve. Surgical level unconsciousness. That's enough for 16 to 32 patients, assuming perfect conditions and no waste. Dr. Brinton had to operate on 47 men. He made a decision. He would administer chloroform only to men whose injuries suggested probable survival. Men who were young, otherwise healthy, and whose wounds were clean. Men with shattered limbs contaminated by dirt. Men showing early signs of infection. Men who had been lying on the battlefield for more than 12 hours. They received nothing, Not because Dr. Brinton was cruel, but because he calculated correctly that those men would likely die regardless, and wasting chloroform on them meant condemning other, more viable patients to conscious surgery. This was the mathematics of battlefield medicine. Save the ones you can, and let the rest endure what must be endured. The men on those tables didn't understand medical logistics. They only understood pain, and that pain was beyond anything most of us can imagine. Let me walk you through a standard lower limb amputation as it would have been performed at a Union Field Hospital in 1863, based on procedures outlined in the Manual of Military Surgery, prepared by the Surgeon General's Office for use by Union medical officers. A soldier, let's call him Private William Chambers, though that's a composite of multiple documented cases, arrives at the surgical station approximately 90 minutes after taking a minia ball through the right tibia and, fibula. Both bones are shattered. Fragments are protruding through the skin. The wound is contaminated with fabric from his trousers, dirt from the battlefield, and powder residue from the discharge that wounded him. The attending surgeon, following standard protocol, makes an immediate assessment. The bone damage is too extensive for conservative treatment, and the contamination means infection is virtually certain within 24 to 48 hours. Amputation is the only option. If chloroform is available, the surgeon administers it by saturating a cloth with approximately 1 ounce of the liquid and holding it over the patient's nose and mouth until consciousness is lost, typically 2 to 4 minutes. The patient is then maintained in an unconscious state through periodic reapplication during the surgery. But let's assume, as was the case in at least 40% of these operations, that no chloroform is available. Private Chambers is placed on the operating table, often nothing more than a wooden door or a section of barn planking elevated on sawhorses. 4 orderlies position themselves, 2 at the shoulders, gripping his arms, 2 at his remaining leg, holding it immobile. A leather strap or a wooden tongue depressor wrapped in cloth is placed between his teeth to prevent him from biting through his own tongue. The surgeon does not explain the procedure. There's no time. There are 17 more men waiting outside, and the daylight is fading. The operation begins. First, the surgeon makes a circular incision through the skin and subcutaneous tissue, cutting down to the muscle layer. He does this approximately 4 to 6 inches below the site of injury, far enough to ensure he's cutting through healthy tissue, close enough to preserve maximum limb length for potential prosthetic use later. This first cut severs thousands of nerve endings simultaneously. Patients who survived conscious amputations universally described this moment as uniquely terrible. Not because it's the most painful part, but because it's the moment you realize what's happening is real. Private Carlton McCarthy of the Richmond Howitzers, who lost his left arm at Cold Harbor without anesthesia, wrote in his 1882 memoir, "The first cut of the knife produces a pain unlike anything else in human experience. It is sharp, yes, but also cold, as if the blade carries winter with it into your flesh, and in that instant, you understand that your body will never be whole again." Next, the surgeon cuts deeper through the muscle layers. He works quickly, using long, firm strokes. Speed is critical, not just to minimize the patient's suffering, but to reduce blood loss. A human body contains approximately 5 liters of blood. Lose 2, and you go into shock. Lose 3, and you die. The surgeon is cutting through the largest muscles in the human body. Blood pours from the wound. An assistant stands ready with a basin, but most of the blood simply runs off the table onto the floor. Once the muscle is cut through, the bone is exposed. This is where the saw comes in. The capital saw, also called an amputating saw, has a curved blade approximately 12 inches long with aggressive teeth designed specifically for cutting through human bone. The surgeon positions the blade against the exposed tibia and fibula and begins to saw. Contemporary accounts from conscious patients describe this part of the procedure as transcendent in its horror. The vibration of the saw travels through the bone into the entire body. The sound, a rhythmic scraping, grinding noise, is clearly audible despite the patient's own screaming, and the sensation defies description. Dr. Valentine Mott, one of the most experienced surgeons of the era, estimated that a skilled operator could sever both bones of the lower leg in 30 to 45 seconds. The femur, being larger and denser, took 60 to 90 seconds. 90 seconds. That's all it took to remove a leg. But to the patient, it felt eternal. Once the bone is severed, the surgeon lets the amputated limb fall. An orderly picks it up and carries it outside, adding it to the pile that's accumulating behind the surgical tent. The surgeon then ties off the major blood vessels, the anterior and posterior tibial arteries, the peroneal artery, using silk ligatures. These ties must be tight enough to stop bleeding, but not so tight that they cut through the vessel wall. It's a delicate procedure performed by a man whose hands are slippery with blood and who is working as fast as possible. Next, he uses a specialized tool called a bone rasp to file down the cut edge of the bone, smoothing any sharp points that might eventually puncture through the skin from the inside. Finally, he folds the remaining muscle and skin over the bone stump like a flap and sutures it closed using silk thread. Sometimes he leaves a small drainage opening to allow pus to escape, a crude acknowledgement that infection is expected. The entire procedure, from first incision to final suture, takes between 5 and 8 minutes for an experienced surgeon operating at battlefield speed. Private Chambers, if he hasn't lost consciousness from pain or blood loss, is then carried to a recovery area, usually just a section of floor with straw scattered on it, and left to either survive or die. No post-operative care, no antibiotics, no follow-up surgery unless complications become life-threatening, and complications were almost guaranteed. Because the real killer wasn't the saw. The real killer was what grew in the wound during the days that followed. Within 48 hours of surgery, nearly every amputation site became infected. The most common infection was what doctors called laudable pus, a thick, creamy discharge that surgeons actually considered a positive sign. They believed it indicated the wound was cleansing itself. They were catastrophically wrong. What they were seeing was streptococcal or staphylococcal bacterial infection. And without antibiotics, once it took hold, it spread. The second most common infection was hospital gangrene, medically termed necrotizing fasciitis today. This wasn't the dry gangrene caused by loss of blood supply. This was wet gangrene, a rapidly spreading bacterial infection that liquefied tissue. Hospital gangrene could consume an entire limb stump in 5 to 7 days. The tissue turned black, then green, then began to slough off in chunks. The smell was overpowering, described in medical reports as sickeningly sweet and detectable from yards away. Dr. Joseph Janvier Woodward, acting Assistant Surgeon General during the latter part of the war, conducted an extensive study of hospital gangrene published in 1863. His findings were grim. Once hospital gangrene appeared in a surgical ward, the mortality rate among amputation patients jumped to 46%. There was no effective treatment. Surgeons tried everything. They applied nitric acid directly to necrotic tissue, a procedure so painful that even men who had endured conscious amputation begged for it to stop. They packed wounds with charcoal, hoping to absorb the putrid miasma they believed caused the infection. They re-amputated, cutting higher up the limb in hopes of outpacing the spreading infection. Nothing worked consistently. The bacteria spread faster than the surgeons could cut. Men who had survived bullets, survived surgery, and survived the initial recovery died in agony as their bodies were consumed from the inside out. Private Samuel Clear of the 116th Pennsylvania Infantry had his left leg amputated at the thigh following the Battle of Fredericksburg in December 1862. The surgery was successful. He survived the immediate post-operative period. On day 6, he developed a fever. On day 7, the stump began to smell. By day 9, hospital gangrene had spread from the amputation site up into his hip socket. The surgeon attempted a second amputation at the hip joint, a procedure called a disarticulation, which is about as horrific as it sounds. They cut Private Clear's entire leg off at the pelvis. He died 36 hours later. The infection had already entered his bloodstream. His death was recorded as a battle casualty. His name appears on the memorial at Fredericksburg as a soldier who died from wounds received in combat. But Samuel Clear didn't die from combat wounds. He died from an infection introduced during surgery, performed in conditions that guaranteed contamination, by surgeons who didn't know they were killing the men they were trying to save. His story was repeated thousands of times, but here's the part that was deliberately suppressed: the men who survived. By war's end, approximately 45,000 Union and Confederate veterans were living with amputations. That number is likely conservative. Confederate records were incomplete, and many men simply vanished into the countryside rather than seek government assistance. They knew wasn't coming. These men returned home to a society utterly unprepared to accommodate them. Prosthetic limbs existed, but they were expensive and primitive. The hanger limb, designed by James Edward Hanger, himself a Confederate veteran who lost his leg at Philippi in 1861, was the most advanced prosthetic available. It cost $75, equivalent to roughly $1,400 today. For a manual laborer or subsistence farmer, that was 3 months' wages. Most amputees couldn't afford it. The federal government did provide pensions, but the bureaucracy was deliberately obstructive. A Union private who lost a leg received $8 per month, barely enough for food and shelter, let alone medical care or a prosthetic. Confederate veterans received nothing from the federal government. They had to rely on individual southern states, most of which were financially devastated. Some states paid pensions, many didn't, and even those who could afford prosthetics discovered they were barely functional. The early models were heavy, uncomfortable, and prone to causing pressure sores that could become infected. Many amputees found them so painful to wear that they preferred crutches. But the physical disability, the missing limb, the pain, the difficulty finding work, that was only the visible damage. The invisible damage was psychological, and it was pervasive. What we call post-traumatic stress disorder today was epidemic among Civil War amputees. But in the 1860s and 1870s, the medical establishment had no framework for understanding it. They called it soldier's heart, or nostalgia, a quaint term that utterly failed to capture the reality of men who couldn't sleep without reliving the surgery, who panicked at sudden sounds, who experienced phantom pain in limbs that no longer existed. Dr. Jacob Mendez da Costa, a Union surgeon, published the first clinical description of the condition in 1871. He documented veterans presenting with rapid heartbeat, chest pain, difficulty breathing, and what he termed an irritable weakness that made them unable to work or function normally. His paper was largely ignored by the medical community. The prevailing attitude was that these men simply needed to toughen up. But toughening up wasn't an option when you woke up every night feeling the saw cutting through your bone, when you felt your missing leg itching and couldn't scratch it, when loud noises made you dive for cover because part of your brain was still on the battlefield. These men needed help. Instead, they got morphine. The U.S. Army Medical Department had been extraordinarily liberal with opiate distribution during the war. Morphine sulfate was the only effective painkiller available, and it was issued in massive quantities. Soldiers were sent home with bottles of morphine and instructions to take as needed for pain. Many never stopped taking it. By 1870, medical journals were reporting what they termed the Army disease, morphine addiction among veterans. Dr. Horace Day, in his 1868 treatise, The Opium Habit, estimated that over 100,000 Civil War veterans had become dependent on opiates. Think about that number. That's 1 in every 6 veterans. These weren't weak men. These were men who had endured amputations without anesthesia, who had survived infections that should have killed them, who had made it home against impossible odds, and the only way they could bear to keep living was through daily doses of morphine. This should have been recognized as a national medical crisis. Instead, it was treated as a moral failing. Newspapers published editorials condemning opiate-addicted veterans as weak-willed. Families hid their addicted relatives in shame. Churches preached against the sin of intoxication. There were no treatment programs, no veteran support services, no government initiatives to address what was clearly a direct consequence of battlefield medicine. The Veterans Administration wouldn't be established until 1930, 65 years too late for the Civil War generation. So these men suffered in silence, died in obscurity, and were forgotten. The long-term medical consequences of Civil War amputations were documented in extraordinary detail by the U.S. Pension Bureau, which maintained records on every veteran receiving disability payments. A comprehensive study published in 1895, 30 years after the war ended, examined the health outcomes of surviving amputees. The findings paint a devastating picture. Of the amputees who survived past 1870, 62% experienced chronic complications requiring ongoing medical intervention. These complications included chronic osteomyelitis, bone infection that recurred periodically, sometimes decades after the original surgery. Each recurrence required surgical debridement, cutting away infected bone tissue. Many veterans underwent 5, 6, 7 subsequent surgeries over the course of their lives. Neuroma formation, painful. Tangles of nerve tissue that grew at the amputation site. These caused excruciating phantom limb pain. There was no treatment except re-amputation, cutting higher to remove the neuroma. But neuromas often reformed at the new site. Stump breakdown, the surgical closure failing years later, reopening the wound. This was often caused by the sharp end of the bone gradually working through the tissue from the inside. The only solution was another surgery to file down the bone and reclose the stump. Each of these complications carried risk of infection, and each infection in the pre-antibiotic era carried risk of death. The mortality data is stark. The average life expectancy for a Civil War amputee was 51 years, compared to 62 years for non-amputated veterans of the same age cohort and socioeconomic background. That's 11 years of life stolen, not by the bullet, by the surgery that followed. In 1890, photographer William Bell was commissioned to create a visual record of residents at the National Home for Disabled Volunteer Soldiers in Washington, D.C. His photographs, now preserved in the Library of Congress collection, show the reality that monuments never capture. One image shows a veteran identified in pension records as Samuel Arthur Decker, formerly Private, 14th Connecticut Infantry. Both arms amputated at the shoulder following wounds received at Cold Harbor in June 1864. The photograph was taken in March 1889, 25 years after his amputations. Decker sits in a wooden chair, his empty sleeves pinned across his chest. His face is gaunt. His eyes stare directly into the camera with an expression that transcends mere sadness. For 25 years, Samuel Decker had been unable to feed himself, dress himself, or perform any basic task of daily living without assistance. He had lived in the soldier's home since 1867 because he had nowhere else to go. Pension records indicate he died in November 1891, 2.5 years after the photograph. Cause of death, pneumonia. He was 54 years old. The records note, almost as an aside, that he had been unable to feed himself for the final decade of his life. Someone else had to place every bite of food in his mouth. This was survival. This was victory. This was coming home. Stories like Decker's were not exceptional. They were common, but they were not commemorated. There are no monuments to the men who survived amputation. No memorials to veterans who died from morphine addiction 30 years after the war ended. No national recognition of the medical catastrophe that shattered tens of thousands of American men. We built statues of generals on horseback. We named schools after battles. We preserved battlefields as sacred ground, but we never acknowledged what happened in the surgical tents. Never admitted that the medicine that was supposed to save these men often destroyed them in ways the bullets never could, because it was easier to celebrate victory than to face what victory had cost. In 1905, Dr. W. W. Keene, the same surgeon who had operated without antiseptics, who had reused sponges on dozens of wounded men, who had amputated limbs under conditions we would now consider criminally negligent, gave an address to the American Surgical Association. He was 78 years old. The Civil War had ended 40 years earlier. He had become one of the most distinguished surgeons in American history, the first to successfully remove a brain tumor, a founding member of multiple medical societies. But in that speech, he said something remarkable. We did the best we could with the knowledge we possessed. But if the men I operated on in 1863 could speak to us now, I believe they would say we did not do enough, that we should have known more, that we should have questioned our practices more rigorously, that we should have admitted our ignorance rather than proceeding with confidence we had not earned. He paused, then added, and they would be right. Dr. Keene understood what we have chosen to forget, that good intentions don't erase suffering, that doing your best doesn't absolve you when your best wasn't good enough. The men who survived Civil War amputations without anesthesia endured pain that no American soldier has faced since. They bore consequences that modern medicine has made obsolete. They lived with disabilities in an era before disability rights, before prosthetic technology, before any societal structure existed to support them. And when they died from infection, from complications, from morphine addiction, from simple despair, they died quietly, unmourned by anyone except their immediate families. This is not ancient history. The last verified Civil War veteran, Albert Wolson, died on August 2, 1956. He was 109 years old. Men who had been held down and cut apart without anesthesia lived long enough to see antibiotics, to see modern surgery, to see medical science advance in ways that would have seemed like miracles in 1863. But they never forgot what had been done to them. The phantom pains never stopped. The nightmares never ceased. The memories of screaming while surgeons cut never faded. We owe these men more than marble monuments and battlefield preservation. We owe them the truth that they were failed, not by cowardice, not by malice, but by ignorance, by a medical system that wasn't ready for the war it was asked to serve, by a society that sent them to fight and then looked away when they came home. Broken. The next time you visit a Civil War memorial, look at the names carved in stone. And remember, those are just the ones who died. The real monuments should be to the ones who survived, because they paid a price that no statue can measure, no memorial can capture, and no history book has adequately told, until now.